And welcome everyone. We're going to get started. Obviously, a very popular issue we're going to be talking about today. Dr. Amir Khosrovaneh, who's our infectious disease specialist on tap lead, has kindly agreed to give us a measles update. Dr. Khosrovaneh provides a lot of guidance, especially through COVID, and we always seek others' expertise when we get into situations like this. There's a lot of uncertainty around how to deal with these. And just another episode of the value that Dr. Khosrovaneh brings not only to our organization, but to our region in general. So, Dr. Khosrovaneh.
Thank you very much, Jimmy. Hi, everybody. Thanks for coming. Today, I'm just going to give some update about the measles, give a current status of what's going on in Ontario and also in our region, and talk about some clinical presentation, differential diagnosis, prevent measures such as vaccination, and some IPAC measures, and also we'll briefly discuss about the measles and the issue with the healthcare workers. Overall, measles is one of the highest, most contagious respiratory viruses, and it remains one of the leading cause of the death in the infants all over the world. Measles vaccination in Canada with a live vaccine started around 1970. The first dose of the MMR vaccine was introduced between 1974 and 1983 in Canada, and around 1996 to 1997, the second dose was implemented all over the Canada. And around 1998, the endemic measles ended in Canada. Means there was no sustained circulation in the measles in Canada since from 1998. So far this year, there are 8 cases of confirmed measles in Ontario. All of them were adults more than born after 1970s. All of them born 1970s, 4 of them unimmunized as children, and 4 of them in adults. 3 of the adults were previously immunized with 2 doses, and 1 adult was unimmunized. All of them, 6 of them associated with the travel internationally, and 2 of the cases, there was no exposure history, including the one that we saw in our region. They couldn't find any exposure history for the patient that was confirmed by SNDHU last week. Just shows the number of the vaccines, source of the measles infection. Most of them are 6 of them again travel related. 2 of them there was no known source. It shows the number of measles since 2013 in Ontario. There was a peak in 2013 and 2014. It came down 2019. There were some few cases during the COVID pandemic. The cases were dropped, and since 2022, we see again increasing number of the cases. This is part of that related to the lack of vaccination. This is the diagram shows the vaccination rate in Ontario, which is documented. It's not very accurate, but it shows you the vaccination rate for the measles from 2014 was around 93% documented. It's gradually trending down, and in 2022, 53% is documented vaccination. In some area of Toronto, in the GTA, the vaccination rate is around 30%. And I think the lowest rate of vaccination also can be seen, it was seen in the Montreal area, which they are dealing with a high number of the measles. So we'll talk quickly about the presentation and diagnosis. I don't think any of us have seen any measles recently. I think the last time I saw it was medical school many years ago. So I don't think anybody has really too much experience with the measles. Briefly, is a febrile illness with the rash is transmitted through airborne disease, and the particles of the measles can remain in the air up to 2 hours after the person leaving the area. So if the person was in the Walmart shopping, and then up to 2 hours, if you go there, you can catch the measles, you have not immune. In the hospital, because of the good air circulation that we have, it can remain on the air in the room between about half an hour to 1 hour after the patient leaves the room. It depends on the air circulation that the patient was in the room. It's highly contagious, as I mentioned. The R naught, as you remember, the R naught for the COVID was 2 to 3. R naught is if one patient has a measles, it can pass it measles to other person to 12 to 16% of the contacts. Again, R naught for the COVID was 2 to 3. This one is 12 to 16. That's why it's very contagious. And attack rate is around 90%. Yeah, and if in the household, non-immune household, up to 90% can get the measles if they are living with somebody who has measles and they are not immunized. The busiest slide, just talking about some important clinical timeline. The incubation period is around 5 to 21 days. During this period, patient can remain asymptomatic. Usually, the median rate is around 10 to 14 days. It starts after this incubation period. It starts with the prodromal syndrome, which is fever and the 3 Cs, either cough, coryza, which is running nose, and conjunctivitis, which is non-purulent conjunctivitis. Patients have these symptoms for about 2 to 4 days, and after that, the rash starts. One of the important features of the measles is that when they started having the rash, they also have the fever. This is one of the most important diagnostic factor that we should consider when we are seeing a measles. When they're starting that rash, they have the fever also. And fever lasts for about 3 to 4 days. If you saw somebody has a fever after 3 to 4 days, it suggests a secondary infection such as pneumonia, which is a complication of the measles. And the rash fades around 5 to 6 days. Rash starts on the face, around behind the hairlines, and then goes down. About the infectious period, the patients are contagious for about 1 day before starting prodromal syndrome, and which is about 4 to 5 days before starting rash, that are contagious up to 4 days after having rash. Day starting rash is day 0. So they are contagious for about 9 to 10 days. Of course, this is for typical person, not immunosuppressed. And if somebody has vaccination before, if somebody is immunosuppressed, the presentation is not typical as this, causing more problem in diagnosis. The recovery phase, that the rash subsides, fever subsides, and then cough subsides. So cough can remain for up to 1 to 2 weeks. So just having cough is not indicating that patient has active infection. It just could, because of the recovery phase. And people who have measles, they develop permanent immunity to the measles. They don't get measles. They don't get measles anymore. Again, just to emphasize, fever more than 38.3 and rash, and at least one of these 3 Cs, cough, coryza, conjunctivitis, you should think about the measles. And you see the rash over there is a blanching rash, which is we can confluent. This is more slides about the rash. Usually the rash, as mentioned, slides around the face before the hair, around the hairlines, and then it spreads down. It's a macropapular, which means it's a small raised or flat rash. It's a spot may join together. It's a confluent rash. And also 2 to 3 days after prodromal symptoms, we can see the copular spots, which is the lesions we can see in the buccal mucosa, in the inner part of the mucosa, buccal mucosa, which is pathognomonic of the measles. It's the diagnostic of the measles. The rash are usually not itchy, and again, when the rash disappears, patients have fever. One of the differential diagnoses of the measles with the kids with the rash, the first one is the enterovirus, it's Coxsackie virus, the same as we call it as hand, foot, and mouth disease. Smaller slide, but the rash in of the mouth is different from the rash we saw from copular spot in the measles. It also causes fever and rash. And unlike measles, you can see the rash on the palms and soles of the hands. Measles usually does not involve the hands and the soles. The other differential diagnosis for measles is the parvovirus, fifth disease. Typical age is 1 to 6 years old. Fever rash started on the cheeks. They call it the slap cheeks. same as measles, spread down to the trunk and the extremity. One differential diagnosis, again, it's not always easy to differentiate between measles, but it's not as confluent as measles, the rashes. And lastly, HSV-6 rosella or 6 disease. The rash starts after fever. Unlike measles, the rash starts with the fever, and this kids, when the rash starts after fever disappears, and on this rosella, rash starts on the stomach and then spreads down. That is not common. It's not starting from the head down. What about measles diagnosis? Because of the uncertainty about the clinical presentation, the diagnostic lab testing is essential for all suspected cases for the measles. There are 2 tests that need to be done, PCR, both in urine and NP swab or throat swab, and also serology tests, IgG and IgM for the measles. Let's start with the PCR testing. PCR testing should be done as an NP swab or throat swab. There is no preference. Both of them either can be done, and it should be done within 7 days of the rash onset. Urine also should be done at the same time to increase sensitivity of the PCR testing. It should be done within 14 days of the rash onset. And usually the PCR testing, they have highest sensitivity in the first few days after starting the rash. In addition to the PCR testing, serology testing needs to be done, both IgG and IgM. It should be done during the acute phase and convalescent phase. Acute phase within 7 days of rash onset, convalescent 7 to 10 days after acute, 10 to 13 days after the acute phase. And again, this is typical timeline for the normal people, but patient with immunosuppression, this timeline is different. The problem with serology test, we should not rely on serology test only because we can have false negative IgM in the patient with the measles. If we do test too early, usually before day 3 of a starting rash, IgM is negative and after that become positive. So that's one of the reasons of false negative IgM. The other one, if the patient is previously vaccinated, the IgM can be false negative. IgM could be also false positive. One of the false positives is cross-reactivity with other viruses, such as HSV-6 we already mentioned. And the other positive cause of false positivity is a low incidence of measles in the community. So bottom line for diagnosis, the PCR is more sensitive for diagnosis. If we suspect measles in the patient with the exposure and testing is negative, we should consider repeating them even after these periods that I told you, 7 to 14 days after discussion with the public health. And again, serology alone is not diagnostic because IgM could be false negative or false positive. Just very summarize that clinical presentation and diagnosis and when to suspect measles. Suspect it when you see the patient with typical signs and symptoms of a fever and rash, especially if the patient is not vaccinated, patient had known contact with the measles, recent travel, or residing in an area where measles cases have been recently identified. Again, just repeating again, because that's the most important point, rash starting with the fever, usually not itchy from head down, and testing diagnosis, serology and PCR, both of them should be done at the same time. We move to the measles vaccination and the post-exposure prophylaxis. Measles vaccine is an attenuated live vaccine. It's highly effective. The first dose effective about 93%. Second dose effective about 97%. It's a very safe vaccine. Fever, causing fever about 15% and the rash about less than 5% and the low rate of anaphylaxis. Few contraindications because the live vaccine including pregnancy and severe immunosuppressive patient. In Ontario, the 2 doses of vaccine recommended. The first dose should be given around 12 to 15 months and second dose around 4 to 6 years old. And these 2 doses need to be separated for at least 28 days. In adults with 1 dose of vaccination, they should receive the second dose if they meet the criteria below or based on the healthcare provider's clinical judgment. If they are healthcare workers, military personnel, international travelers, or post-secondary student, then they are eligible for the second dose vaccine. And this is also a recommendation for the travel. If you are traveling and have one vaccine, you'll be eligible for the second vaccine. I'm not going through all of them. But what about post-exposure prophylaxis? So if somebody exposed to the measles, there are two options. If patient has been seen for within 3 days after exposure, we can give a dose of the vaccine. It's not contraindicated. It should be given within 3 days. It prevents or decreases the sensitivity of the clinical course. It can be given after 3 days, the vaccine, but it does not affect for the current exposure. It can prevent the future exposure. For the current exposure after 3 days, it's not effective. One problem with the measles vaccine, as I mentioned, is a rash. The measles vaccine can cause rash in 5% of the people. The rash is not contagious to the others, and usually is a shorter in duration than the rash caused by the disease. During this time, if you do PCR testing, can be positive 14 days after vaccine. So that's causing sometimes problem if you give the vaccine after exposure. It has caused some problem with the diagnosis. It's difficult to know that the rash is because of the disease or because of the vaccine. There's a specific test PCR done. Usually, I think CDC will do that, but I don't think it's available here to differentiate between the rash caused by the measles vaccine or rash. It's a rash by the disease. It's something to know about this rash. And if the patient is not a candidate for vaccine as that contraindication to the vaccine post-exposure, there's an option we can give immunoglobulin again to the pregnant people. For the infant less than 6 months old, because the vaccine is not a license for the less than 6 months old, and for immunosuppressed patients. It should be given within 6 days of the exposure to be effective. And when you give IVIG, we cannot give the vaccine to the patients up to a few months, 6 to 8 months after the IVIG, because the vaccine then is not effective. Any vaccine. Moving to IPAC measure on the preventive IPAC measures. Since we have increasing number of the cases in the Ontario region, we update our site, RVH site, and Public Health also updated their site for patient education. And we are advising patients if they have any exposure to notify healthcare provider or hospital before arrival, so we know we are dealing with them on the start isolation right away. And we also enhance our triage and we also enhance our screening in the ER and putting in new signages. So when we suspect a patient in the ER, we should give a face mask to the patient and put in isolation right away. We should put the patient in negative pressure room or airborne infection control room. And if the room is not available, we should put in the private room with the door closed. Again, room should not be used after the patient leaves the room. It depends on the air circulation of the room. It's usually between 30 minutes to 1 hour to 70 minutes at the hospital. We should notify public health of any suspected or exposed patients right away. Overall, in general, limit patients' movement in the ER or patient being admitted, limit patient movement, and visitors should be just only confined to the essential visitors. And as mentioned, if indicated, consider vaccine or PPE for susceptible exposed patient. I think SMDHU started measles vaccine last week. They are updating their site on a regular basis to show the size of the exposure and provide information about the vaccine and post-exposure prophylaxis as needed. Moving back to IFAC measures, so for all healthcare workers, they should wear N95 regardless of vaccination status or immune status. If they see a patient with suspected or confirmed COVID, confirmed measles or exposure to the measles. When you see a patient in the ER, our recommendation at this time to start on airborne contact droplet means N95, face mask, gowns and gloves till we figure out what's going on, and after that we can assess what kind of PPE needed. But overall, minimum PPE should be N95, and above that, it should be based on the PCR app for confirmed cases. Just review the PCR with you again very quickly. If you think your hand exposed to the blood or to the excretion or secretion of the patient, you should wear gloves. If you think your eyes or face will be exposed, face shield should be used. And if clothing or skin will be exposed, then guns should be exposed. Just overall PCR, not related to the measles, just overall for review. Patient counseling is also important. It's important to isolate. Patients should be isolated as soon as possible. As mentioned, total of 9 days, 4 days prior to rash and 4 days after rash. Immunosuppressed patient should be isolated for the duration of the illness. Could be up to 2-3 weeks. During this time, if patient is at home, should avoid contact with high-risk individuals and or attending public areas. And if assessment is needed, reassessment is needed, again, they should call a hospital in advance so we know patient is coming to a starter isolation right away. And lastly, talk about measles and the healthcare workers. Again, based on the current policy, only immune healthcare workers should be assigned for the care for the patient with known or suspected measles. What's the definition of the immunity in healthcare workers? We should have 2 documented doses of measles vaccine that's given after 1 year and 1 year of the age and 4 weeks apart. That's the definition for the healthcare workers. Or you have IgG documentation by the serology. Or previously you were diagnosed with the measles and your lab confirmed PCR based on the PCR test. Previously, clinically diagnosed measles is not sufficient. So if somebody told you that somebody diagnosed you with measles 20 years ago, 10 years ago, it's not sufficient that you are immune to the measles. The only evidence for the immunity is that these 3 criteria. What about serologic testing after measles? If you have 2 doses of vaccination, serology is not necessary because it's not adequate. So if you have 2 doses of vaccine and do the serology and serology IgG is negative, it doesn't mean anything. If IgG is positive, it shows confirmation that you are immune. But if after 2 doses of vaccination, IgG is negative, is not sensitive because it may not be sensitive enough to detect post-antibody levels. And in these cases, again, so for now, as of now, booster dose is not recommended. So as long as you have 2 doses, no need for serology, and booster dose is not recommended. I think is the last slide. What about if you are exposed to the patient with COVID? If you are immune, you have to notify occupational health, people health safety as soon as possible. Monitor for your symptoms for about 21 days. Work restriction is not needed at this time, and the post-exposure prophylaxis is also not needed. If you are not immune, you exclude from the work duration to be determined by the PHW, and you may need post-exposure prophylaxis on a PRN basis. I know the occupational health is working with all the departments to get updated vaccination of the status and immune status of the all people, all workers. So that's a brief measles summary. I'll be happy to answer any questions.
The table over Julio is so thanks so much for coming. Wow, you're a celebrity. We haven't had this many people grand rounds ever. So thanks so much for putting this together very quickly. Amir actually approached Bryce. We got to get some information out there because as you can see, it's obviously needed. So that was a great presentation. I'm gonna pass this around for any questions. But the first question I have is people are coming to emerge for testing. But why would somebody need to be admitted to hospital for measles? Like, what would be the indication? Like, somebody needs to actually come in for measles. Are there any complications of measles that we need to know about?
So if you suspect somebody with the measles, the complication of the measles, I didn't put that. One of them is pneumonia. Again, as I mentioned, usually the fever subsides after rash about 3 to 5 days. If you saw the fever after that 3 to 5 days, you should consider secondary complication of the measles, such as pneumonia. If the patient is confused, if the kids usually they have confused, you should consider encephalitis. It's one of the reasons for admission to the hospital. Pneumonia and encephalitis is most likely because of the complication, not because of the initial measles.
Got it. So in those settings, we might see measles people as inpatients or as incidental cases, if they're admitted with somebody else, if this does spread further.
Yes.
Right. Question that I might. I'll run over because I'm not people online to hear this.
Two questions. First question is, roseola is a false positive. Yeah. You can imagine roseola is very common, probably one of the most common examples we see in the emerge. Given that false positive rates are dependent upon the prevalence of disease, how would you interpret it if you had a patient who seemed like they had roseola, but because of the pressure you control the test, and then you have a positive IgM, is that interpreted as a positive case or a negative case?
Yeah, again, roseola, the rash starts after the fever, which is one of the important differential diagnoses, and the rash starts on the trunk and then goes down. So it's two features we can differentiate between roseola and the measles. And if the patient has no known exposure to the measles, and the patients have history of vaccination and have these two features, so most likely presentation is roseola. And again, when you send the IgM, you should not send IgM alone. You should send PCR for the measles also. So IgM positive alone, without negative PCR, and with all these features, it mostly indicate the false positive results.
To interpret IgM versus if PCR was negative and IgM was positive, and clinically we thought it was roseola.
Yeah, this is evolving. Yeah, I think it's a good idea to discuss all of these cases with the public here. But the case that you're describing, just again, negative IgM, positive IgM, negative PCR, and these features is just false positive.
It's tough because we get pressure to test people who we think have roseola. So that's a tough situation. My second question was just whether or not we actually have access to the MMR vaccine and IgG if indicated in the emerge.
I think we already discussed the ER. There are 5 to 6 doses of IgG available in the ER.
Thanks. I see Iris got a mic over there too. Other questions for Dr. Khosrovaneh? Okay, at the back.
I was just wondering if the clinical presentation would be different for patients who, say, have had 2 doses and are vaccine non-responders. Would you still expect them to have the textbook presentation or something more atypical?
Yeah, 2 doses or patient, immunosuppressed patient, yeah, it's atypical presentation. The rash could start from the trunk and go down. The fever could be, they may have not fever with the rash. So it's a very difficult diagnosis. It's not straightforward, unfortunately. And again, diagnostic test is also not in the timeline. They could have negative IgM. They could have negative PCR. It's a very difficult diagnosis. So exposure history is very important in these cases.
There.
Sorry?
The vaccine numbers for people who are.
Sorry, can you repeat that?
For those who are vaccinated, do we have any statistics on reinfection for those individuals?
No, we don't have the statistics, but as I mentioned, the cases that they saw so far, the cases that saw this year, I think 3 adults were fully vaccinated.
I think right now, my understanding, Amir, and what I have been online too here, is that a lot of what we're seeing is people being sent in to merge to get testing by public health. And they're pretty sensitive. They're saying a lot of people with like generic viral reactions, as Mike was alluding to. And then it's kind of, obviously, it's kind of clouds of emerging your testing. Hopefully, public health will have a strategy to be testing people in their home or somewhere else. Because the treatment of most of these cases, as far as I know, is to go home and just see isolate. Like, they get really intubated or admitted, for measles, unlike the good patients who come in. So it's really trying to store that pathway better because you don't want everyone coming to emerge, but like most things, emerge is kind of where you go to when there's no better place. The other issue that I see in the public health is, sorry.
So their goal is to prevent the secondary case. So far, all of these cases, there was no transmission found in the Ontario. That's where I think the SMDH trying to prevent the secondary case after the exposure that they're recommending come to the ER. There is no other else they could do the testing because of the negative pressure room and the isolation.
Yeah, exactly.
But hopefully they'll find some way to.
Where that goes, right? I mean, they're going to send home and go over there within 35 and the last thing to do it there, right? I think the other thing is that public health, I understand public health updated their website and through UHT, we send a consistent message to people about kind of where to go because there's a lot of confusion in the community right now of what to do if you suspect you have measles or a loved one or you've been exposed. So hopefully that clear messaging across the healthcare board is helpful as well. Okay. Other questions for Dr. Khosrovaneh? Oh, questions online, thanks, Mitch. Okay, so Amir, would you recommend that a child who's turning 4 later this year receive their second dose early? If so, will it be recognized in the routine immunization schedule for school, or would they require a third dose on schedule as well?
So the child got the first dose and it's 4 years old. It's still not recommended to the vaccination at this time. Maybe if they see more cases and secondary transmission, maybe they change their approach. But so far they haven't recommended. For now, only if the kid is traveling, it's recommended to get the vaccination.
So stay on schedule for children. So, and if you're an adult who've had 1 shot, do you recommend just getting a second shot right now?
Second shot, again, is not the. I don't think it's publicly funded. Second shot only publicly funded in the healthcare workers, military personnel, secondary students, and travelers, or at the discretion of the healthcare providers.
Unless you expose
Yeah.
training. Other questions for Dr. Khosrovaneh? Let's go.
That if you're exposed, you get the vaccine. So do you come to ER, you just let them know?
So if you've had both, my understanding is if you've had both shots, you do not need post-exposure prophylaxis for the third dose. It's only if you only have 1 or 0 shots, you then need a shot within 3 days. Is that
You
right?
don't have to come to the ER. I think the SMDH have some vaccination clinic. The people can check the site and go to the.
And he called the public health. And they referred him to Angus, because Angus had availability for giving out the, because he only had 1 dose as a kid. So that's kind of how we handle it right now. It's just call public health and then they'll tell them where to go.
Good, excellent questions. Any further questions for Dr. Khosrovaneh? Mike?
I just wondering, so there is a discrepancy between the national guidelines for timing visa vaccination and our routine immunization schedule in Ontario. So the Canadian guideline says the second dose can be given after 18 months minimum before we can go. Is there like a reason for that, or any reason why we shouldn't just use the Canadian guideline?
This is, I think, it's a publicly funded because of the patient don't have to pay. I think the main reason, one of the exclusion because of the Ontario publicly funded, is the recommendation from the Ontario. And the NASH one is also about the same, 12 months and the second dose before age 7.
Yeah, that was correct. The ECI deadline for second dose being after months, maybe as early as 18 months.
No, the minimum is 24 weeks, but the best time is to give it before age 6 or 7. But it can be given minimum after 4 weeks after first shot. For travelers, you can get the vaccination. I didn't discuss that. This is a slide. This is for travelers. You can get the second dose of the vaccination as long as the 4 weeks after the first dose. And it's publicly funded.
I have a friend listening online with a very newborn baby. She's wondering if the baby is protected from her vaccinations that she had a long time ago, or she would have had to have been vaccinated during pregnancy for the baby to be
How old is the baby?
4 weeks old.
But they are usually protected by up to 6 months. And if there is any
Vaccinated during pregnancy.
if there is any exposure, if the kid is the infant is less than 6 months, then they may need IVIG after discussion with the public health and provide if exposed.
If someone has one MMR, 5 years come back not immune, we administer a second MMR, what is the timeline when we consider that person immune? Is it 14 days, 28 days?
It's usually 14 to 28 days, yeah. At minimum is 14 days, yeah.
It's even 28 days?
Yeah, if the second dose is 14 days, yeah.
Any other questions? Good ones. Okay, I want to thank Dr. Khosrovaneh for coming. On your tables, there's a QR code. Please fill out the surveys. Any physicians and PAs in the room, if you fill the QR code, we will send you a CME certificate. So please do that if you can. We really want to improve ground. This has been an amazing one. Again, I want to thank Dr. Khosrovaneh not only for coming, but for initiating this grand rounds and providing some really valuable information. So thanks so much, Amir. Appreciate it.